Let's study about cystic fibrosis. Cystic fibrosis prevalence is more in Caucasians that are United Kingdom residents. African African American the prevalence is 1 in 15,000, in Asian American 1 in 31,000, Native Americans 1 in 80,000, and Indian migrated to UK 1 in 10,000 or 12,000. The molecular genetics of cystic fibrosis is it is autosomal recessive disease. It is due to mutation in the gene CFTR, that is cystic fibrosis transmembrane conductance regulator, that is present on chromosome number 7. Most common mutation that occurs in CFTR gene is phenylalanine, that is present on 508 position, is deleted. The pathophysiology of cystic fibrosis is due to CFTR gene defect. There will be defect in chloride channel, and this chloride channel is responsible for the efflux of chloride, bicarbonate, and water. Then the efflux of water, bicarbonate, and chloride is not possible due to defect in chloride channel. There will be low water content in lumen. There will be periciliary dehydration that will result it into highly viscid mucus. Then the cilia will not be able to work normally. Clinical manifestation of cystic fibrosis is meconium ileus, obstructive jaundice. As you can see that due to defect in chloride channel, that all the secretions will become more viscid. Obstructive jaundice, hyperproteinemia, anemia, bleeding diathesis, heat prostration, hyponatremia, failure to thrive, steatorrhea, rectal prolapse, bronchitis, bronchiolitis, staphylococcal pneumonia. Staphylococcal pneumonia, as the respiratory secretions are viscid, they will not excrete out by cilia movements, and by the time there will be infection in this viscid mucus. Steatorrhea, pancreatic secretion, exocrine secretion will also be viscid, and there will be decrease in lipase that will result into steatorrhea. There will also be decrease in amylase that will result into osmotic diarrhea. Bronchitis and bronchiolitis, due to presence of viscid mucus, there will be inflammation and will soon result in bronchiectasis, and this will result in recurrent pneumonia, and death may present due to this. 2 to 12 years of age, there will be malabsorption, recurrent pneumonia, nasal polyposis, as nasal polyps are present in the mucus. As nasal polyps are present in the nose, there will be nasal stuffiness, and due to more exposed area to the air, there will be epistaxis. In more than 13 years of age, chronic pulmonary disease, clubbing, because by the time there will be severe hypoxia. Abnormal glucose tolerance, as the endocrine function of the pancreas is also disturbed, so there will be decreased insulin secretion, result in diabetes and abnormal glucose tolerance. Chronic intestinal obstruction, focal biliary cirrhosis, as the stasis of the bile. Portal hypertension, liver diseases will result into portal hypertension. Gallstones, stasis of the bile. Azoospermia, typical phenotype. Diagnosis is made by typical phenotype if there is any family history. First is by high sweat chloride test, and at 2 occasions the value should be greater than 60 milliequivalent per liter. And if we found equivocal test results of 2 occasions, then we will do nasal potential difference test. And for confirmation, we will identify the mutation in both copies of CFTR gene. For management, respiratory management by airway clearance, giving antibiotics as staph pseudomonas is growing in the respiratory mucosa. Give antibiotics, anti-inflammatory agents as there is bronchiolitis. Nutritional management, increasing calorie intake, feed the child more frequently. Maybe if the child is infected for a long time, there will be decreased appetite, so feed him by the nasogastric tube or gastrotomy. Supplement fat soluble vitamins in twice the recommended dose and given along with food and enzymes. And other is give enteric coated tablets of pancreatic enzymes with each feed.